ROC. Let me close the data also. Okay, this thing. So this ROC is basically this. We will have, I think, 2 breakout room in this ROC. And we'll try this time that because the concept is little long, so we want to like half of this I will take in one snapshot, and then again you will go to the breakout room, and then again I'll take the other half, and then again you will go to the breakout room. So this is your again ROC. Now this full form of this ROC is the receiver operating characteristics curve. So what is this ROC basically? So starting with again one question, you got a new tool or a new instrument, and you have to make a decision using that particular tool or using that particular, probably if it is any test, whether a person is suffering from any condition, and that condition is, let's say, X. So you applied this tool or this test on randomly selected sample, and from that you can say you got these values. So these are the case ID from 1 to, let's say, 16, and these are the individual value of the diagnostic test. So looking at these values, can you tell like who is suffering from the disease and who is not? There is a value. So based on this data, you cannot say, like, because we don't know anything about the instrument, we don't know the cutoff, so we cannot tell. But again, if I have got like two disease status, in this case, the green color is for the for the healthy, and this orange color is for the diseased one. So you have got the actual status of the person also. Now and these are values are your new instrument test result. So if seeing this, if you see like these are the diseased people where the value of this particular instrument is like 24, 21, 22, 28. And if someone is healthy, it is like 4, 17, 10, 7, 11, and 14. So can you tell a rough what could be the cutoff based on which we can classify? So Dr. Ravi is saying 18 and 20. So yes, you can say like 18 or 20. Seeing this, you can say like it is 22. All the people who are more than equal to 22, they are diseased, and less than that are not diseased. Or even if you take 18, that is fair enough. So now I can see the cutoff, because I can say which is the cutoff because I have the actual disease status with me. So if a person comes to my clinic, if I'm sitting in the clinic and any person comes to my clinic and he's suffering from this hypothetical situation, and the values, and I have ordered this test, the value of this test comes out to be 22 or even 18 or 20, like Dr. Ravi is saying. So what will I say? Will I say that the person is suffering from the disease based on just the data which I have seen? Will I say yes or I'll say no? What will be your answer? So yes, she or he will be suffering from the disease based on the available data. And if the if the test value is 16, if I say that the test value is 16, and this person has visited for any consultation, and I am suspecting that of course, I was suspecting that's why I have ordered this test. So will I be saying that he's not suffering from condition? Can I say based on the cutoff of 16 that no, you don't have this disease? Yes, I can say that because the value is 16. So in this case, if you plot a curve, I mean graph, on the x-axis, it is the test value, and on the y-axis, it is the number of people showing these values. So you have got a clear cut. This is a clear cut graph when there is no overlap. So this is my probably this is my cutoff, which is 22. So everyone who is, let's say, this is your these are the number of people. So 16 people, 23 people, 29 people. this how I am plotting the graph. So there is a clear cut demarcation and there is no overlap. So I will say that this is the test which has got, if this cutoff is 22, this has got 100% discrimination power. That means there are if the graph is separated and there is no overlap, so I can say that yes, there's no overlap between the graph. But again, if the actual situation is something like this, where there is a diseased person, but the value is 7, and there is a healthy person, where the value of this test is 22. So now, again, if I see more people, there is a diseased person where the value is 15, and there's a healthy person where the value is 24. So now, can I say that with confidence, if a person again comes to me in the clinic with the same situation, can I say that if he has got a value of 22, he is suffering from the disease? So no, I cannot say, because here you can say even if the person is having a value of 24 in this case, he is not suffering from disease. So now I cannot say with confidence that you are suffering from disease. And even if the person comes to me with 16, can I say that you are not having the disease? Again, I cannot say, because in this case I can see that even if the person has got a value of 7 and 15, in this case 7 and 15, still he or she is having the disease. So now I cannot say with confidence. And now the plot which you have seen, there will be a slight overlap in this plot, because now it cannot delineate 100% between a person who is diseased and a person who is not diseased. And again, there might be more overlap of these two graphs. And these two graphs, if you see, this depicts the true negative. And this depicts the true positive. Why? Because this is your cutoff. So any person having the cutoff of more than 22, we call it as a true positive. Less than that, we call it as a true negative. And in real situation, there's a quite overlap between these two situations. So now I cannot say that I can 100% discriminate between the two pair, which is one person healthy and one person disease. But can you select any cutoff point which can 100% discriminate between a person with condition X and person without condition X? Can I say that? I think no, we cannot do that. We cannot. There will be overlap. So in real situation, whatever you decide for a cutoff, it will always misclassify. And what happens to misclassification? So there will be overlap. And yes, you are right. So overlap. So there will be false positive cases. This is your false positive cases. And there will be cases which will be false negative. So both these false positive and false negative will be there. And again, what will happen to the cutoff? So like if you decrease the cutoff, instead of now the cutoff point is 22 for this example. But if I decrease the cutoff, what will happen? If you decrease the cutoff, your sensitivity will increase. Why? Because there will be more. Now, because you have decreased the cutoff, now even with the normal, if the person is having a value low also, since you have decreased the cutoff, that person will be labeled as a disease. But actually, he will not be having the disease. So there will be more number of people who will be false positive. Again, if you increase the cutoff, then what will happen? So if you increase the cutoff, definitely there will be more persons where this test will say that it is negative, but they are not the true negative, they are the false negative. So that happens with increasing or decreasing cutoff. If you decrease the cutoff, there will be increase in, like if you are decreasing the cutoff, so it will have more sensitivity. But again, if you have got more sensitivity, there will be chances that you are labeling many normal people as a false positive. Similarly, if you increase the cutoff, there will be high specificity, but you will be labeling people who are actually having the disease to be not having the disease, which is false negative. And the real situation is much more complex, where you are having the true positive, true negative, false positive, and false negative. So I need a technique which can tell me, like for an individual cutoff, what will be the value of these sensitivity and specificity and the predictive values, and which I can decide for a best cutoff. And that's the purpose of ROC. So this ROC, or the receiver operating characteristics curve, this helps you to decide the optimal cutoff for your test, whichever you are like proposing a new test. It can be for a tool also, it can be for a model also. Like in case of logistic regression, those of you who have attended logistic regression, there also you propose a cutoff, that is the AUC in the same interface. And in the survival also, you have seen that it is also giving you the Harrell C index and concordance index, just to discriminate these, whatever model you are proposing, what is the discriminatory power of that model. So this receiver operating characteristics curve analysis, that initially it was developed during the World War II, which using this analytical technique, they were able to discriminate between a sound which is coming, or the waves which is coming from a noise, and wave which is coming from a radar. So that time it was developed. So now, what are the uses of ROC for us in health? How we can use this ROC analysis? So if you're proposing a new tool means like if you have developed some tool, you have calculated the sensitivity and specificity, and you want to tell the cutoff, because without cutoff you cannot say like what is the sensitivity and specificity of your tool. Then you can use this ROC. Or if you are developing a model, means a logistic regression model, then also you can use this ROC to say the cutoff. In case of a logistic, generally that cutoff is decided by the software, because that cutoff we fix it at 0.7, 0.5. But you can increase or decrease this cutoff, and you can see the sensitivity of your model. So it basically helps us to decide a cutoff value based on which we can say like this person is having the condition and this person is not having the condition. That means if you take a pair of people, one having the disease and one not having the disease, this ROC analysis, it tells you basically the AUC which I am telling, that which has got the disease and which person has not got the disease. So suppose this is just a graphical representation. In this case, it is, we are trying to show if you decrease the cutoff, what happens to the sensitivity and specificity. So generally you will see that the sensitivity and specificity are inversely proportional to each other. That means if you increase sensitivity, your specificity will decrease. If you decrease sensitivity, your specificity will increase. So they are inversely related to each other. In this case, here in A, you can see there are three different cutoff. In A, it is having a cutoff of here, and then you are going towards the right. That means you are increasing the cutoff. So if you increase the cutoff, what happens? Your sensitivity decreases. So that's what I have written, that if you move the cutoff threshold from left to right, there is a decrease in sensitivity. And this you can see, this is again a ROC curve. So sensitivity, this is for point A. So this point is getting plotted by A. This is for B, and this is for C. So basically, what is the ROC? At each, you can see here at each cutoff, it draws 2x2 table, and it calculates sensitivity and specificity. And the graph is plotted between sensitivity on y-axis, and on x-axis we take 1 minus specificity. And this graph is known as the ROC curve. So there is a decrease in specificity. There is a decrease in sensitivity and there is an increase in specificity. Because if you come down here, there is a decrease in 1 minus specificity also. But there will be increase in specificity. So sensitivity, as I said, that they are inversely related to each other. If sensitivity decreases, your specificity increases, and vice versa. Again, this is one graph. You can see we have just shown you there is a crossing, and here this is the common area where you can see there's a false positive and false negative. So this area is for the false positive and this area is for the false negative. If you just want to see how your ROC will look, so ROC looks like this. So graph, it is here in first case, if there is a slight overlap, which is a very natural and normal situation, then your ROC curve will be something like that. If the overlap is more, then it will come closer to this diagonal line. And if there is a too much of overlap, then you can say it will be very much near to this diagonal line. That means it has got no discriminatory power, because in this case, it cannot discriminate between the positive and the negative. So this was the uses of ROC curve and the ROC curve. Now, what are the advantages? Because ROC is a graphical representation of this data, this diagnostic accuracy. So if there are multiple tests means you have devised 2, 3 tests for the same disease status, then you can compare for these multiple tests. Again, you calculate something known as the area under the curve. That is the value which the software gives us. So this area under the curve is a non-parametric and it is unaffected by the this population parameter. So you don't need to check for the normality of the data, and it works well even if the data is non-parametric, the non-normal. And you can decide for the cutoff. So when do we use ROC curve? So ROC is when you have got make some model, like in case of a logistic regression, you are performing binary logistic, then you can use, or you have proposed some new diagnostic test or some prediction model or something, any tool which you have developed, there also you can perform. So like Dr. Ravi is asking, for screening tests, should we have high sensitivity? Yes, true. For screening test, we should have high sensitivity. And for diseases which are like less this thing and associated with stigma and discrimination, like HIV, cancer, for those cases, because you are labeling that disease, so you need high specificity. So that's the trade-off between sensitivity and specificity, which you have to decide depending on your objective. So what is the characteristics of ROC? Again, we have talked about this. This is a plot between the sensitivity on the y-axis and 1 minus specificity on the x-axis, and 1 minus specificity is the false positive rate. So basically it is the graph between the false positive and the true positive rate on the x and y-axis. And if the graph is closer to the diagonal line, then we say that it is a poor discriminatory power. And if the graph is closer to the top and towards the left, then we say that it has got a good discriminatory power. And test accuracy is shown by the area under the curve, which we call it as a AUC. So ROC is, again, we have learned that in the binary logistic regression also. So you develop a model and you predict the occurrence of a outcome with the help of certain predictor variable. And this you have predicted that this is a person. So this we are predicting, let's say if the cutoff is 0.5 here. So if the person is 32-year-old male, resident of a rural area, obese and diabetic and smoker, and if I have proposed some model, and if I put that person under that model, so that model has calculated a probability for this person. So if the probability is 0.665, so what will I say? I will say that the disease outcome should happen in this case. Why? Because the cutoff point was 0.5 for me. And since this has got a probability of 0.665, so this person should have the disease. But if the cutoff is but if the probability is 0.365, what will we say? That outcome should not happen. But if I increase the cutoff, let's say I increase the cutoff to 0.7, then what will happen? In that case, if at the same 0.665, I will say that the person is not having the disease, and this even if it is 365, the outcome should not happen. But what if I lower the threshold? So if I lower the threshold to 0.3, then what will happen? In both the probability, whether it is 0.665 or whether it is 0.365, I will say that this person will have the disease. So you can see that the probability of occurrence of a disease will depend on the what cutoff we have set. Similarly, what ROC does, so in this case, what the predictive model is doing? So predictive model is like making a 2 by 2 table with all that cutoff. And then it gives you the probability and it gives you the sensitivity and specificity of your cutoff like this. So we have calculated this in the binary logistic using a 0.5 cutoff. If you are proposing in the binary logistic model, what is the sensitivity, specificity, likelihood ratios, and predictive values of a particular cutoff of your model. because there what we do, we say that what the model has predicted, whether he will have the disease or not have the disease, and what is the actual category. So there is a 2 by 2 table for cutoff, and model propose, I mean, with your model, with the 0.5 cutoff, you convey the sensitivity, specificity, likelihood ratios, and the predictive values. So can I say that the model has fixed value for all these diagnostic accuracy statistics? I'm calling these statistics as diagnostic accuracy statistics. So diagnostic accuracy statistics, if I say this term, you should understand that I am talking about sensitivity, specificity, predictive values, likelihood ratios, and accuracy. So if I can say that a diagnostic accuracy, if a model, if in logistic, if I'm proposing some model, it will have the fixed values of these sensitivity and specificity. Can I say that? Yes or no? So yes, of course, for a particular cutoff, you can say, but if you change the cutoff, then your answer will be no. So it depends on the cutoff what we set and the group membership which that particular person belong to, which again depend on the cutoff. So for a particular cutoff, we can say that these diagnostic accuracy statistics will be same, but with different cutoff, it will change. So now how to decide this cutoff? How to decide whether it is what should be my cutoff value? So I've got three options. So if I already, like Dr. Ravi was saying, if I'm looking for a more sensitive one, so I can have this higher sensitivity. I will see each cutoff and I'll decide the tests which are having high sensitivity. If my objective is to have high specificity, again, I will go for a cutoff which are having high specificity. But again, if I want to have a trade-off between high specificity and high sensitivity, then I'll use something known as the Udens index. So this Udens method or Udens index, Jamovi gives this as output. It calculates this and it gives you the output, which tells you which cutoff you should use, which is the optimal balance between the sensitivity and specificity. So to evaluate all these three options, we need to run the ROC analysis. So software, actually, what does the software does? Actually, it calculates the sensitivity and specificity for all values, of your cutoff value, and then it gives you a graph. So if you plot a graph like this, sensitivity and specificity, it will be something. Your graph will be something like this. So it will be difficult to calculate the area under the curve. That's why generally what we do, generally we take something, we need a parameter, because where if you increase the sensitivity, that will also increase. So that's why we take 1 minus specificity on the x-axis, because then your graph will be something like that, like this. If you take the 1 minus specificity, your graph will be something like this. So then you can calculate the area under the curve. So this ROC is what? It is the plotting of sensitivity on y-axis and 1 minus specificity on the x-axis. So this is your false positive error rate and this is your true positive. And then area under the curve, this is calculated using a calculus integration formula, and this area under the curve, that gives you the discriminatory power of a test. So this value indicates the overall discriminatory power of the model, and there are various cutoff for that. So in model also, whenever you are doing some binary logistic, you use different set of predictor variable, and then you can compare the AUC of all different predictor variable. You can test it with 3, 4, 5 and so on, and you can see like which model is giving you a high AUC value. So this you can see that it is the diagonal line. So diagonal line, that means it is random. Means even if you don't, discriminatory power is nil. That means you can randomly say which will have the disease and which will not have the disease. Then it will come as a diagonal. Any graph which lies above to this diagonal line is the performing good, and lower to this diagonal line is performing poor. So the curve is, it separates this area into a two space for a good and poor performance. And ROC, what is ROC? Basically, For each cutoff, it calculates the individual point. So these point which we'll see in the graph, these points are the individual points, and when you connect these points, then it plots this as a ROC curve. So what is ROC? Basically, it is a point with a pair of X value and a Y value, and there are so many points using each cutoff, and that when you join these lines, that's the ROC curve. So starting point is 0, 0 and end point is 1, 1 on this ROC. So again, if you see this is a perfect test, the line, if the graph is lying above this diagonal line, and if the graph is lying below this, then it is you cannot take any decision. If you see this blue and red, if I ask from you which one is better, blue one or the red one, yes, all of you please type in the chat box which has got a better AUC if you just see the graph. Yes, blue is better. Again, in this case, although it is written, so they are writing like worthless, good, and excellent. So yellow is having the, yeah, true. So I think we have done this comparison. You can compare more than two. So what is this area under the curve? Basically, this area under the curve, that is a situation where patients are collectively classified into two groups. So if you make a pair of people, one with disease and one without disease, so this area under the curve, it tells you how the percentage, what is the percentage of the correctly classifying the two people. So it is if you see the definition, this area under the curve, that is a percentage of randomly drawn pair for which the test correctly classifies the two person. That means it is saying that if you randomly pick one person from the disease and one person from non-disease, and you make so many pairs, and that software makes that pair, and it sees like using that cutoff, what percentage of those pairs it can classify correctly. And that is the area under the curve. And same concept is being used in case of a Cox proportional. That C index and the Harrell C index, that is using, I mean, the concept is little different, but that is again the discriminatory power only, the concordance index and the Harrell C index. And if you see the values also, it is similar to that. So how do you classify this? What will be the interpretation? So if it is 0.5, you say that there is no discriminatory power. If it is 0.5 to 0.7, you say poor. And if it is at least 0.7 should be there. In case of a survival, we accept 0.6. Why? Because of censoring of data, it is slight less. It is 0.6. That Harrell C index and C index, the value of those C indexes are 0.6. But in case of AUC, at least 0.7 should be there. So more than equal to 0.7 is the acceptable. If it is 0.8, 0.9, it is excellent. And if it is more than 0.9, it is outstanding. So these are the values of IUC for which you can classify. So again, Udens index is like we have talked. What is a Udens index? Udens index help you to decide for an optimal cutoff, taking both sensitivity and specificity into consideration. So the formula for a Udens index is like you calculate, it is the maximum. If you see, it is the maximum value of sensitivity and 1 minus specificity. So if you change this formula, you can write it as a sensitivity minus 1 minus specificity. That means it takes this into bracket and take out the minus sign also. So it is basically, it is sensitivity minus 1 minus specificity. That means there is a x-axis and y-axis. So if you remember ROC, on y-axis you have got sensitivity, which is this one. On x-axis you have got 1 minus specificity. So basically Udens index is this minus this. So the maximum value of J, it is your Udens index, and it gives equal weightage to the sensitivity and specificity. So the prerequisite is like you should have sensitivity and specificity across all cutoff points. Suppose this is my 2, so I should have 2 by 2 table for all cutoff point. So suppose this is my 2 by 2 table, and similar 2 by 2 table, the software makes in the background to calculate the sensitivity and specificity. So what is a positive test? So positive test is like if some disease is there, actual disease is there. So, and your chest x-ray shows that pneumonia is there or not there. But if a positive, against some gold standard, your test should show whether the person is having the disease or not having the disease. Suppose if there is a gram stain, we say that the bacteria is there. Suppose if the chest CT is showing a pulmonary embolism. So if there is a CT is showing, can I say that he is actually having the disease or not disease? So how to decide for a positive test? When there is a continuous data. In case of a categorical, of course, you can compare it with the gold standard. But in case of a continuous, this thing, how you will decide? So how it does, suppose this is just for demonstration, this is one article, and the title of this article is, Does Leukocytosis Identifies Bacterial Infection in Febrile Neonate Presenting to the Emergency Department? So there they have, like their objective is to evaluate the discriminatory power of the peripheral WBC count. So they want to see whether the peripheral WBC count can uh, identify the, which babies will have fever, like infection. So they are uh, using this leukocytosis to identify bacterial infections. So what they did, they have taken, like, let's say 66 children. They have taken the WBC count of all children, and they have taken the actual status of disease. So for this, whenever you do a ROC or the sensitivity and specificity, you should have a column where you should have an actual status of disease. So in this case, you can see, based on some gold standard, the person is having a status whether the disease is there or not there. And then for each cutoff, let's say he has decided for a cutoff of 4 WBC count. So he will make a 4 by 4 table, 2 by 2 table of having a cutoff less than 4 and more than equal to 4. Similarly, for value of 6, taking this cutoff point, he will plot. I mean, he doesn't do it like software does. So the software calculates these many cutoff using the cutoff value of, like, let's say 11, 7, 15, 23. It calculates the sensitivity, specificity of each of these. And then it calculates the Udens index and sees like which Udens index is maximum. And then it suggests that yes, this should be the cutoff. Like the author got the result like this. So he has given for like these threshold, like for 5, 10, 12, these are the cutoff which he has taken. So these are the sensitivity and specificity, positive predictive value and negative predictive value, likelihood positive test and likelihood negative test. So this output you get in Jamovi. So this again, you can here there are two ways. Jamovi gives you a cutoff based on the Udens index. But if you wish to have your own cutoff, whether you want to have a high specificity or high sensitivity, seeing these you can select. And this was the area under the curve plotting which he has suggested for white blood cell. Again, this is one article, Diagnostic Marker of Infection, Comparison of Procalcitonin with C-reactive protein and leukocyte count. So here what he must have done, like he has taken one column of this procalcitonin because he's having two tests. Comparison of procalcitonin and with C-reactive protein and leukocyte count. So objective is to evaluate comparing procalcitonin with C-reactive protein and procalcitonin with the leukocyte count. So he took the value of a procalcitonin, CRP in another column, and the WBC count. And this is the septic shock, which this is the true status. So he has given the cutoff of all the three values, procalcitonin, CRP, and then taking both procalcitonin and CRP. So he has again given the sensitivity, specificity, PPV and NPV of these cutoff. And then he has plotted all these three ROC together. So this procalcitonin, CRP, and this leukocyte count. And you can see he is suggesting that PCT. So the graph, how do we say that graph which is towards the top and towards the left, that has got the best discriminatory power. So this has got the no discriminatory power. This is the middle, and this you say it is the very good. And if you see the area under the curve also, it is 0.96 for procalcitonin. 0.83 for CRP, and it is only 0.5. So we say that 0.5, that means it is near to diagonal. That means it has got no discriminatory potential. So how to compare? Again, you can compare this using the comparison status in the Jamovi. So before I go to the other options, I think first I will demonstrate this, then you will go to the breakout room, and then we'll see the other options. So now let's see the data set. We have shared the question to them. We have shared the question to them. I think to you people, let me go to the day 3. Okay, this is not the one. So I'll show the data. Sorry, paper. So this is the base paper which we have used. A waist to height ratio of 0.54 is a good predictor of metabolic syndrome in 16-year-old male and female adolescent. So if you see the paper, they have done a cross-sectional study of 678 adolescent, and they have calculated the weight, height, waist circumference, hip circumference, BMI, and waist hip ratio, waist height ratio. And they have also estimated the metabolic syndrome. Metabolic syndrome, they have used this guideline, and then they have given the various cutoff. So if you see the metabolic syndrome, they have used these 5 risk factors: abdominal adiposity, high blood pressure, hypertriglyceridemia, low HDL, and fasting hyperglycemia. And at statistical analysis, they have performed the ROC curve, and they have calculated all the diagnostic accuracy statistics, which is sensitivity, specificity, predictive values, likelihood ratios, and the accuracy. So if you see the result, if I go down, it's there, the plotting of the ROC curve. I'll open the data set. Let me open, I think. So this is my data set. You all have this data set. We'll see this one by one. This is your gender, male and female. This is your age. Age is in continuous. Let me change this. Again, you also change. First, you check the data. See the weight. Weight is continuous. And then you check for height is again continuous. Waist circumference continuous. Hip circumference, BMI, waist hip ratio. All these continuous. And metabolic syndrome, you have got 0 and 1. So 1 means presence of metabolic syndrome and 0 means absence. So this is the data. Now coming to the question, I have to see the cutoff of so objective is to evaluate and compare the discriminatory performance of BMI, waist hip ratio and waist height ratio. to determine the metabolic syndrome. I think by mistake it's written cardiovascular disease. Okay. So I will, in case of a ROC, I think we have asked you to download 3 modules of ROC from here, and those 3 modules are the diagnostic, this one, diagnostic ROC, and there was a JYS. But the most important one is the diagnostic ROC. So we will demonstrate from this. So click on this diagnostic ROC and this run ROC analysis. So if I click this ROC analysis, there is a dependent variable which is a continuous. So my dependent variable are 3 variables. I have to see BMI, waist height ratio, and waist hip ratio. These are the 3 variables, the continuous one, and this is the metabolic syndrome against which I have to see. And the event one means the metabolic syndrome has happened. That means presence of metabolic syndrome. And then I'll see the ROC curve. So these are the 3 ROC curve. So if you see this blue one is for waist height ratio. So that is the best one because it is the upper top corner. Then these two are not having a very good, both the BMI and waist hip ratio. And if you see the AUC, it gives you the AUC. So AUC of BMI is 0.61, which is not acceptable. Minimum should be 0.7. Waist hip is again 0.6. But waist height is good. It is 0.96. Okay. And p-value, if you see, if there are more than two, this thing, so I'll tell you that later on. So first you only compare this. And if you see like it using this, a cutoff, which automatically this decides based on the Udens index, it calculates 2 by 2 table. So for BMI, it is suggesting a cutoff of 22. And it calculates on the 22, it calculates the sensitivity, specificity, positive predictive value, all these tests which we have just discussed. Same using waist hip ratio, it is giving you a cutoff of 0.512 based on Udens index, and it calculates the sensitivity and specificity with this. And these are the sensitivity and specificity of the cutoff of 0.51. And then there is a waist height ratio 0.9, and it has also got like tells you the sensitivity and specificity. So this is the comparison. So first we will learn this, you practice this, and then I will take the another half where I will demonstrate few more options in case of this ROC. So in case I think we have got. So now we learn, till now we have seen regarding the comparison of ROC curve and the cutoff which Jacobi suggests based on a Udens index, what will be the 2 by 2 table and what is the diagnostic accuracy values of your cutoff that you have seen. Now coming to the predictive values and likelihood ratios. So to show that, there's one example that let's say in a population of 20 cases, if you know that 5 are positive, and I know that from a gold standard, and I applied a new test on these 5 cases, and it shows that 4 are positive out of 5. So what is the sensitivity of this new test as compared to the gold standard? So I might say, yes, you can all type in the chat box. If there are total of 5 cases and I have applied this test, so what is the sensitivity of this new test as compared to the gold standard? Yes, 80%. True. Similarly, if there are 20 cases, I know that there are 15 cases are HIV negative, which are from a gold standard. And I applied the new test on these 15 cases, and it showed like 12 being negative. So what is the specificity of this new test as compared to the gold standard? So it will be 12 by 15 because there are a total of 15 negative cases and 12 are being shown. So what is the limitation? Yes. So there's a limitation of these sensitivity and specificity, because actually they do not provide any information on probability. So what is a probability? Probability means if the patient comes to me with a test, so can I say that actually he is having the disease or not? Because for a clinician, whether I should treat the patient, whether I should start the treatment, that depends on this context, that if the patient has come with a positive result, is he having the disease or not? Because you might remember and recall the time between COVID, whenever like there were many kits which were there in the market, which were testing like COVID positive and COVID negative. But what about the predictive values? That means if the test has come positive, what is the likely chance that I will have actually COVID? Because for treatment or for isolation, suppose initially like there were quarantine centers and you had to put the people on quarantine or maybe isolation. If it is COVID, you have to put them in IC and strictly isolating them from every other person. So if you have to label someone, you need something which has got a high predictive value. Means if the test has come positive, what is the probability that he will be suffering from the disease? So for that, just to show that example, suppose there are two people. There's one person who is resident of Manipur, where the prevalence of these HIV is highest as per NACO report. And there's another person in Kerala, where the prevalence of this HIV is lowest as per NACO report. So if these two people come to the ICT center, for the ICTC center for checking their HIV status of the hospital, so and both tested positive. So what is the probability? Which person will have the more probability of having HIV? Yes, all of you please type in the chat box. Manipur. Yes, because the prevalence of the HIV is very high in Manipur. So although both have tested positive on the same test, but my interpretation will not be the same, because I will see like where the person is coming from, and I might see other risk factors as well. So how to convey this to patient? So for this, we need something known as the predictive values. So what is the predictive value? Because if the patient has come with the test positive status, whether he is actually having the disease or not, how to convey that? So now there are two types of predictive values. There is a positive predictive value and there's a negative predictive value. So formula, I think you all know, and even if you don't know, I think it's only interpretation which is important. But again, what is predictive value? So out of test all those tested positive, if you see how many of them are true positive. So in numerator, we take true positive, and in denominator, we take the total positive. That's a predictive value, positive predictive value. Coming to negative predictive value, what is negative predictive value? So all those tested who are true negative, and in denominator, we take as tested negative, like means total negative. So in numerator, we take true negative, and in denominator, we take total negative. So we say if positive predictive value is high, that means a positive test is highly reliable in confirming or refuting the presence or absence of disease. That means if any test has got a high positive predictive value, let's say 80% or 85%, I can say that there's a 85% probability that this person will have the disease, because the probability of having the disease is high. Similarly, if the negative predictive value is high, I can say that if the test has come negative, there's high chances that there will be no disease in such person. But again, there are limitations of these positive and negative predictive value. These are again dependent on the prevalence of the disease in the local setup, and because you know that there is a wide variation of the geographical prevalence of disease. So these predictive values are dependent on the prevalence, and they are not the inherent nature of the test. So to overcome this problem of positive and negative predictive value, uh, there was a need to devise for something which is inherent to the test, and this should be not dependent on the prevalence. So then comes the positive and negative likelihood ratios. So what is a positive likelihood ratio? Basically, a positive likelihood ratio, in this case, we are focusing on the positive test result. That means if the test has come positive, so what is the probability that the positive test result is actually showing the presence of disease? That we take in the numerator. And in denominator, we take that what is the probability that the positive test result will come if the disease is not there. That means in absence of disease. So the numerator, that means positive test in case of a presence of disease, that is your true positive rate. And positive test in absence of disease, that's your false positive rate. So basically this LR plus is the ratio of the true positive and false positive rate. That means true positive rate we write as a sensitivity and false positivity as 1 minus specificity. So basically this LR plus is the ratio of sensitivity and 1 minus specificity. So if a test has got high LR plus or the high likelihood ratio, positive likelihood ratio, that means we say that there is high indicative of the presence of disease. And there's a beauty of this LR plus that it is independent of disease prevalence. So that's why it is like in a particular, it is universally, you can say that it is universally acceptable because this is not related to your geographical prevalence of disease. Similar coming to the likelihood negative ratios. So what is a negative likelihood ratio? Here we focus on the test result which has come negative. So in the numerator, we take the negative test result in the people who are actually having the disease and probability of a negative test result in people who are actually not having the disease. So in numerator, what will have? It will have false positive rate because if the result is showing negative, but actually it's the probability of a negative result. Actually, where actually there was a disease. Actually, it's not the false positive probably. Because if there is a negative result and actually it was a presence of a disease, so it's a false negative actually. In the numerator, it is false negative, and in denominator, it is true negative. So it is again a ratio of 1 minus sensitivity and specificity. So low, this LR negative, it tells you that again the negative test is highly indicative in the absence of disease. So like LR plus, this LR minus is also independent of the disease prevalence. So this, what is a good likelihood ratio test? So if the value of, you should remember this only, if the value of positive likelihood ratio is more than 10, then we can say that there's a strong ruling. That means that's a good. You can say that he is having the disease. And if the value of negative likelihood is less than 0.1, then we can say it's a strong rule out. Means the person is not having the disease. But again, there are limitations of this likelihood ratio, positive and negative also. Because even if you know that likelihood ratio is 12 or 13, how you will inform the patient and how you will take a clinical decision? Because you need to convert these likelihood ratios into the post-test probability. What is post-test probability? After the test result, what is the probability that the person will have the disease? And this clinical decision making is generally done on this post-test probability. So now coming to another concept, which is the pre-test probability and post-test probability. So what is this pre-test probability? So basically this pre-test probability even without testing the disease, without ordering the disease, if through the clinical judgment or based on the prevalence, if I can say what is the probability that this person will have the disease. For example, if the prevalence of anemia in pregnant women is 70%. So if I am seeing patients, even if I don't order test, there are chances that out of 10, if I label all of them as having anemic, I will be correct in 7 cases because the prevalence is very high. So because of my clinical judgment, even if I don't order the test, there is some probability of a particular test, I mean particular disease. So this is the likelihood that the patient will have the disease before a diagnostic test is conducted. And it is usually the clinical judgment based on patient history, symptoms, or the prevalence of disease. Now, what is a post-test probability? So probability, this post-test probability is after receiving the diagnostic test. So this is derived from the pre-test probability and the likelihood ratio. And this post-test probability that helps us in deciding the next step in the patient management. So there is a formula. You don't have to do it actually. Just in the background, what is happening that we are explaining. Otherwise, these you get in the as a output in Jamovi. So how do we convert in the session of logistic regression or otherwise also you know that odds can be converted to the probability by using this formula. So if you know the probability, you can convert that to odds. So odds is equal to probability divided by 1 minus probability. Similarly, probability is odds divided by 1 plus odds. So how these probability and LR ratios are correlated. So generally, this is an important formula that post-test odds is equal to pre-test odds into likelihood ratio test. So what is this post-test odd? So this you first calculate post-test odd and then through post-test odds you calculate the post-test probability. So this is again the same thing which we have seen, like you have got this. How do you do this? First you have got the pre-test probability. So what is a pre-test probability? It is the clinical judgment, or for example anemia, I said like if it is 0.7. So that is your pre-test probability. Through pre-test probability, the software calculates the pre-test odds. So pre-test odds is calculated based on this formula, P by 1 minus P. And then we calculate the post-test odds. So post-test odds is calculated using this formula, pre-test odds, and this likelihood ratio positive if we are calculating for the positive one. And then you calculate the pre-test probability where you put this post-test odds here in the numerator, and in denominator you do the 1 plus post-test odds. So this is just to demonstrate what is happening in the background. You don't need to calculate it. Just remember how these odds and probability are getting converted to each other. One thing you can remember that post-test odds is equal to likelihood ratio multiplied by pre-test odds. So based on this, Jamovi gives you the outcome in the form of a nomogram, which I was discussing in the Cox regression. There also the option of nomogram is there, which will appear in version 2.7. Right now it is not complete. But in case of this ROC, it gives you a nomogram, which is also known as the Fagan's nomogram. And this is used to visually estimate your post-test probability from the pre-test probability and likelihood ratio. So we'll see this and then again. So we completed up till this point, this ROC comparison. I was about to tell you that if you have got more than two tests, then you can compare it with the D-long test. There's an option written here, D-long test, which you can use to see in between comparison. And then, like here you can see, it gives you the output of pairwise comparison. So it is significant, both. Waist height ratio is significant in both. It is p-value and it tells you the difference in AUC. So this is the pairwise comparison using D-long test. If you click this display coordinate table and display all coordinate points, then for each coordinate point, it gives you all these values. This is just to show. You don't need, because the main one you have got. You can all click this accuracy and prevalence, and then with each cutoff. So there are many cutoff of BMI. So it will give you a output of all the cutoff of BMI with waist hip ratio, because here it has given you, in the previous command, it has given you only one cutoff, taking the this Udens index. But if you want to decide on your own, if you want to have a more of sensitivity or more of specificity, then you can check each of these points and then you can say it is taking time. I think I should close this and again open this or what?
पूरा आता है.
And that's why it takes time. Actually, it gives you a very huge table. Still, it doesn't buffer that long usually. Let me close this and again I'll open this. Because many times, so this is ROC. I will put this event here. Event level. Oh, this is not R. Sorry, this is your COX. Let me. It is taking time and the older version 2.3 is getting open. Let me close that.
2.3 खुला. दोनों वर्षन खुला है.
2.6.26 that I open. So till the time it is, because it is taking some time. But without that output. Okay, so in the meantime, okay, it has come. I'll go to this diagnostic ROC and ROC analysis. And this ROC, I will put that Mets event is 1. All these 3 variable to dependent. I will compare this we have seen earlier. I need coordinate table and display all coordinate points. So till the time it is appearing, I will try to explain few more concepts. Because in ROC, if you see, in the JAMOV, there's a new option which tells you like if you take some cutoff and then it calculates the relative risk, odds ratio, risk reduction, which is the relative risk reduction, absolute reduction, and the number needed to treat. All these options you will get in the JAMOV. So just to take some basics of these concepts, I know many of you know this, but what is a risk reduction? So to make you understand, suppose if there are generally with vaccine, we explain this. So suppose you have taken 1,000 people as a control and 1,000 people as a intervention group. You have given vaccine to 1,000 people, and to the other 1,000 they have not received the vaccine. So after 1 year, if 10 people in the vaccine group they got the disease, and after 1 year, 50 people in the control group got the disease. So how I will make the 2 by 2 table? This is not a 2 by 2, but if I need to calculate the risk, so how will I calculate? So the calculation of this disease risk is like 10 divided by 1,000. So it will be 1%. Similarly, in case of if the person is not taking the vaccine, the risk of disease is 50 divided by 1,000, which is 5%. So if I have to explain what is absolute risk reduction, if I give the vaccine, so your absolute risk reduction will be the risk in the control and risk in treated, because the risk is higher in the people who have not received the vaccine. So the absolute risk reduction will be 4%. And if I ask you the relative risk reduction, so your relative risk reduction will be your absolute risk reduction, and in denominator, you take the risk in the control. So risk in the control is 5%. So the relative risk reduction will be 80%. And what is number needed to treat? So if you divide this absolute risk reduction in the denominator, 1 by absolute risk reduction is your number needed to treat. So what is number needed to treat? What does this 25 mean? So this 25 says that you need to vaccinate 25 people to prevent 1 case of that disease X. That we mean by the number needed to treat. So these values, this JAMOV gives you these also. So now you can see, since this was so long, that's why it was taking time. Can you see? It gives this cutoff of BMI. For every cutoff, it calculates sensitivity, specificity, and Udens index. You can see this is so huge. That's why it is taking so long. You don't need to put this actually. Just to show you that how it calculates the Udens index. So actually it gives you the one value of Udens index, which is the maximum value. The cutoff value of that, taking Udens index as a criteria. And then you can have like these two positive and these thing here also, but I'm not clicking since you have gotten this from here, taking this 22. So based on this Udens index, this has given the cutoff of 22. And and it gives you the specificity, sensitivity, positive and negative likelihood ratios, prevalence, and the accuracy also. Now coming to the plots. These are here generally you have got these curve as a combine here. But if you want these curve to be separate, you can uncheck that. And if you click on these coordinate points, then we'll see how this appearance of this changes. So I'm unchecking this for now because this lengthens the table too much and the output. That's why I'm unchecking this now. No, it is. So till the time it is coming, I will show you with another this thing. So suppose here it is showing you the value of BMI as 22.065. So this is your 22.065 is the cutoff. And this is your 2 by 2 table, 63, 237, 30 and 270. So using another, so this was for one. Now for Fagan's nomogram, I need to use another module, which is in this one, optimal cutoff selection. So I will go for this second option. And here you can see if I decide for this 22.065, so which is my test or exposure variable. So my test or exposure variable is this waist hip ratio. Sorry, BMI, not waist hip. I am using the BMI as a cutoff. And what is my value? More than equal to 22.065. This is my cutoff, which I took from the ROC analysis. And my reference variable is your METS. This is my disease variable where the 1 is the event. And now I need to see this post-test probability where I have set this pre-test probability as 10%. Means I'm assuming that if the cutoff is more than 22, then generally what is the prevalence of this metabolic syndrome? So let's say the prevalence of metabolic syndrome is 20. So I have put this pre-test probability as prevalence as 20 and I click on this Fagan's nomogram. Then you will see that this output here also you get that sensitivity, specificity, positive and negative likelihood ratio test. And then it gives you the post-test probability. So like we were discussing, like how will you calculate the post-test probability or how the post-test probability is calculated? So generally the post-test probability is calculated taking the likelihood ratio positive. So it has calculated this LR positive likelihood ratio multiplied by the pre-test odds. This one. Remember, we have discussed about the conversion of pre-test and post-test odds and pre-test and post-test probability. So actually that is happening in the background, but you get this. The post-test probability of the likelihood positive is 27% and the diagnostic test, this post-test probability for this negative test is your 13%. So, and this is your Fagan's nomogram. So how to interpret this Fagan's nomogram? So this, if you see, here is the value. It starts from 0.1. So from up to down, this pre-test probability is increasing like this and post-test probability is increasing in this direction. And then on the mid one, there is a likelihood ratio. So how you have to, like how it plots, initially it takes the pre-test probability. So this is a pre-test probability. So it was 20%. So it is 20%. And now you see what is the likelihood ratio positive. So if I go up, the value of likelihood positive ratio is 1.45. Ideally, we discuss that if it is more than 10, then only it is good. But just for demonstration, if you see 1.45 comes here, this green one. So this is your 1.45. So it uh, connects the line of this pre-test probability and likelihood ratio positive, and then it extends here to this line. And this is your post-test probability. So the post-test probability is 27%. What is the meaning of 27%? That means if the patient has tested positive, there is a 27% chance that like probability that he will have this disease. So it is having a very poor post test probability, because for this there's only 7% increase. Without testing also, the pre-test probability was 20%. With test, there's only 7% increase. So it is not a good test. Similarly, the diagnostic test negative is, if you see the probability, it is 13%. And we have said that if it is less than zero point 0.1, then only it is good. Sorry, the likelihood negative. So if we see 13.2, how will we interpret that? If the person has tested negative, there was only 13.2% probability that he will actually not have the disease. So both these are having a very poor. Why? Because if you see the AUC only, for demonstration, we have shown that. But AUC is very poor. AUC is only zero point 0.6. It was 0.62. If I show you the above one, the comparison of AUC of BMI is 0.61, which is very poor. You can check with any other. Let's say waist. Let me check it with waist height ratio. So waist height was 0.51. Yes, this was waist height 0.51. If I put here more than equal to 0.515, let's see, 0.515. And here instead of BMI, you take waist height. Sorry, 0.515. This value I am taking. And then you see what happens. Now, if you see the Fagan's nomogram, see the post-test probability is 76%. This is so good now, because the pre-test probability was 20%. That means if you don't uh, conduct the test, you can only, out of 100, you will be only correct in 20. But if you conduct a test, then out of 100, you will be correct in 76.2%. So there was an increase, too much increase in the post-test, and your post-test probability for negative test is also good, because it is saying that only 3.0% chances that the person will have the disease. So you can see here, and LR, this thing also you can see, positive likelihood is 12. It should be more than 10. Negative likelihood should be less than 1.1. It is nearly 0.1. So this is how you interpret. So for Fagan's nomogram, you have to use the option from here, the first option, this one. This you will use for like comparison if you want to compare. But if you have got a selected cutoff using this option, then using that cutoff, you can plot your Fagan's nomogram and you can tell about your post-test probability for both positive and negative test. Is that okay? Then we'll go to the breakout room, and then I will take the third part, which is the relative risk and odds ratio. So all of you, please go to the breakout room. Yes. Okay, Parvati said yes. Okay, Parvati, thank you. So now we'll see this number needed to treat. So we have just seen the basic concept, what is risk reduction, what is absolute risk reduction, what is relative risk reduction, and what is number needed to treat. So how we can apply this in case of a cutoff. So again, Jamovi gives you like with the particular cutoff. Let's say if you have put the cutoff of BMI at 22 or this waist height ratio at 50.51, then how this cutoff will predict the risk in case of people. So how to understand this? So let's say I'll just show here. If this is 2 by 2 table, first I'll explain. Using this, then we'll go to that particular output. So this was cut off using this BMI cutoff of 22.065, where it is saying that 63 accurately, true positive was 63 metabolic syndrome. And so what will be risk in high BMI group? So in high BMI group, the risk will be this 63 divided by 300, that is 21%. Similarly, the risk in what will be the risk in low BMI group? In the low BMI group, it will be 30 this divided by 300. So it will be 10%. So your relative risk will be risk in the exposed. Exposed here is the high BMI group, and risk in the non-exposed. Non-exposed means in low BMI group. So this is 2.1. That means we can say that risk in people who are having high BMI, this risk is risk of metabolic syndrome. So risk of metabolic syndrome is 2.1 in people with high BMI as compared to low BMI. And coming to relative risk reduction. So generally that risk reduction is the term initially coined for some intervention program. But since here we are talking of cutoff, that means here there is an increase in risk. So the relative risk increases. What will be the increase? Generally, with the previous example, what we have seen, that your relative risk reduction will be your absolute risk, and in the denominator, you take the risk of control. So here, what will happen? It will be absolute risk reduction. So what is absolute risk reduction? Here, it is not reduction, it is increase. It will be 11%. That means 21% minus 10. So 11%, and in denominator, we will take risk of low BMI, which is 10%. So your relative risk increase is 110%. That means as compared to the people who are having low BMI, there is an increased risk of 110% in person who are having BMI more than 22.0. And how will we interpret the number needed to treat? So number needed to treat is the term initially coined for the vaccine or some intervention program. Here we will say number needed to harm because it's a negative thing. So how do we, what is the formula? So formula is 1 divided by absolute risk increase. Here it is increase. So absolute risk increase was 0.11. So your number needed to harm, it is 9.09. So how do we interpret it? So we say that if there are 9 people having BMI more than 22, then there will be one person who will develop the metabolic syndrome. This is how we define number needed to harm. Means 9 people more than 22 will harm one person. That means he will have metabolic syndrome. Again, odds ratio is calculated. It is a cross product ratio. So it will be calculated like 270 multiplied by 63. In denominator, it will be 237 by 30. So it is 2.39. So we say that odds of this metabolic syndrome will be high in the people who are having more than 22 of BMI as compared to low BMI. So now coming to this.
But ma'am, both are having different values coming into play.
Both means?
I mean, the odds ratio and the NNH.
Yes, it is different because NNH we describe in terms of risk. NNH is 1 by absolute reduction, risk reduction. Whereas this odds ratio is, odds ratio.
Okay.
So you are saying, you want to say like this, you can say about this relative risk and odds ratio. Like relative risk is 2.1 here and odds ratio is 2.39. So this is little similar. Why? Because if the prevalence is less, then value of both relative risk and odds ratio are very near to each other.
Correct.
But you cannot compare like NNH and OR. Are you getting? So now coming to this output. So this, I have not shown you this relative risk and odds ratio. So I've ticked this relative risk and odds ratio, and this table you will get. Just I was explaining you. So relative risk is 2.1, as we have seen from 2 by 2 table. This absolute risk reduction is 0.11. That means this is actually, it is not risk reduction. That's why the sign is minus here. Because risk reduction happens when there is a control and there is an intervention minus control, then we say risk. But here actually there is a harm. So that's why there's a negative sign. That means that there's a risk is increased in the people who are having more than 22 BMI. This is again relative risk reduction is again relative risk increase. And this number needed to treat, although it is a number needed to treat, but in bracket you can say it is writing harm. Here also it is writing harm. Harm means it is saying that if it value 9.09 means if there are 9 people having BMI more than 22, then there will be one person who will be harming by it. That means he will develop metabolic syndrome. And this is your odds ratio. If you like, instead of BMI, if you wish to see it with the for that waist height ratio, what was the cutoff of waist height ratio? It was like 0.5. Let me see.
0.515.
So if I put here, like I will put BMI here and I'll put waist height here. And instead this I will put as 0.505. Yes.
0.515.
Okay, so
515.
I'll put 0.515. And then you can see what is how to interpret. So this gives you the relative risk. So relative risk is very high. The person who is having the cutoff like more than 0.515 waist height ratio, the risk is 30 times more in that person. Similarly, odds ratio, if you see, it is 100. It is so high. And if you see absolute risk reduction, that means absolute risk increase. It is 0.68, means 68%. Person who is having this waist height, this having 68% and relative risk increase is again, you can see this many. And number needed to harm is again, even if only 1.47, actually you will multiply it, since it is in fraction, you may multiply it by 100. So you will say that if there are 147 people having high waist height ratio, there will be 100 people who will develop metabolic syndrome. Am I making myself clear?
Yes, yes, ma'am. Ma'am, can you just go down, please?
Yes.
Ma'am, this in the pre-test and the post-test, there is this dotted line which goes and picks up both the 20% at the pre and the post-test, and it is zero point 0.5 in the LR. What does this particular dotted line indicate?
This tells you like when the LR is 0.5. I think what will be the meaning of this dotted line? It just tells you
Because
like if the
because because
pretest,
because the
yeah,
red one is the negative and the green one is the positive, ma'am.
agree.
I wanted to, because this question even Dr. Kamran had raised in the chat. So I thought you
Okay.
would be the best person to answer.
Yeah, I've not thought, but since you have asked, so this 0.5, if you see likelihood ratios, this comes because this is somewhere in between. See, for negative, we say that the value, for positive, we say that it should be more than 10. But again, 0.5 and 20. So it is the same, like pre-test and post-test, if it is having same probability, the value of 0.5 is like a null. Okay, yes. The value of 0.5 is like a null. If the value of the probability, whether it is positive, it is 0.5, it is null. That means there is no increase or decrease in the pre-test and post-test probability. If you see,
LR1 is cutting through actually 1. It is not 0.5, ma'am. Where the point it
but
is
yeah,
cutting.
sorry, 1. I'm sorry. It is 1. Let me. I was just, yes. It is 1. true. So if it is crossing through 1, it is the null line. Because if you like extend it here, there is no change of post-test probability. It is exactly the same as pre-test. So this is the line of null, and above which we test for positive and below which we test for negative. So that's if the LR is 1, generally you take it as a null value, and because in this case when the LR is 1, whatever if you pass that line through this 1, your pre-test and post-test probabilities are same. That means there's no need. This test result is having zero nil for yield for you. What do I mean by zero yield? That means even if you don't order a test, there is no change in the probability. So it's the decision line basically. So this dotted is the decision line. We call it as a decision line, or what I have understood is like it's the null value. Both these pre and post is same 20, because we have considered this. And even if you order or don't order a test, this will be your null value. So based on this, you decide like it goes up and down, the negative or the positive test. Is it okay, Dr. Ravi and the other person, Dr. Kamran?
Yes, ma'am.
Okay.
Yes.
So I think, do you want to practice this, or it's 4:20? If you want to practice this, we can go to breakout room.
Ma'am, we've already done it, ma'am.
Okay.
It
So
was already open on the.
okay, you've done this relative risk and odds ratio interpretation? No, not this one. I want you people to practice one saying this interpretation of all this. Do you want to do that, or do you don't want to go to the breakout room? Then we may like take a call whether to continue or to stop here. Since participants are less, so I can ask.
Better to continue, ma'am.
Okay, so if you wish to continue, then again we will go to the breakout room. In the breakout room, what you do, you try to explain these terms. What is the meaning of these terms? So again, I'll repeat, there's a relative risk, there is absolute risk change. Ideally, I think they should now have this term absolute risk change, because change will be like increase or decrease. But since it is a negative sign here, so you might think that there is a risk increase is there. And then the relative risk reduction, the number needed to treat, what is the meaning of number needed to treat, how to convey that. So you can try doing with the waist hip ratio or any of the three cutoff, which you have.
Sorry, I want to say you continue, but I think so very few people, so breakout time maybe longer time, so maybe they want to
Okay.
finish it.
Okay. So I'm sorry. I got you wrong. I thought you want to practice. Okay. So if you want me to continue, so I've shown this with this one thing. And again, then, so if you wish me to say, then I wish to introduce one more term, which is the
Ma'am,
F1.
ma'am, can you just go up on this table, ma'am? It
Yeah.
shows that there is a 3% the diagnostic act, ma'am, no, below, ma'am, below. Yeah. So the diagnostic test negative, the post-test probability is 3%, which means that it can miss out on 3% of the people who are actually positive.
That means if the test is coming negative, out of 100, there are only 3% chances that person will actually be having the disease.
So that is basically the false negativity will be approximately 3%, right, ma'am?
Uh, Generally false negative, then again we'll go to that. It is a post-test probability. So how we say that, if you order a test and the test result has come up negative. So if you see 100 people and if the test result has come up negative, then this is your the post-test probability is 3%. That means out of 100, there are 3%, like 3 people will be actually the diseased. If 100 people are negative, then there are 3% chances that they will have the disease. That's the interpretation.
So it will be in the sense that 3% people would not have missed the disease but will have the disease.
Can you repeat it?
Ma'am, my query is this, that when you say diagnostic test negative on 3%,
Mm-hmm.
what will it exactly mean?
You
Will
want
it
to say,
mean
I
that the
think,
test has not accurately picked up those 3%, or is it the other way around?
see, the pre-test probability is 20%. I think you explained, no? And Dr. Shamshad is explaining this, I think. You will, because
what is pretest probability here? We are assuming 20%. That means even if we don't have any test, we can say by guess that 20% you have a 20% chance of getting disease. You remember the HIV example? Suppose the prevalence of a disease is very high.
Yes. Sir, you please continue. We're listening to you, sir.
Then suppose I am saying that without any predictor, without any test, you have a 20% chance of getting metabolic syndrome. Now you just tell me your BMI. Now BMI is 18. The moment I got the idea of BMI and through this second chart, I will say that your post-test probability now reduced to 3%. If the BMI is above 22, then I can say that your post-test probability now increased to 76% from 20%.
actually, it's the using the same cutoff. Like if you have taken BMI as, because here in this case it is the, since not the BMI, it is waist height ratio. So if waist height ratio is 0.51, so what do you mean by diagnostic test positive? First to tell me that. That means what do you mean by diagnostic test positive? That means that person will be having either the waist height ratio 0.51 or more than 0.51. So if you measure that person and if the waist height ratio is more than 0.51, then your post test probability, the positive test. What do you mean by diagnostic test positive? Because here I mean that the BMI, the waist height ratio, it is more than 0.5. And what here in this case, diagnostic test negative means the waist height ratio is less than 0.5. So if a person comes to you and if he's having a value of the waist height as less than 0.5, so he is having only 3% probability of having the metabolic syndrome. Pre-test was 20. If you don't measure that person, you will say that there is a 20% probability. If you have taken the waist height ratio, then it has decreased to 3%. So it's a good indicator. If your negative has decreased and positive has increased, that means you are coming to like near ideal this thing. That
So the cutoff here, ma'am, you said but here you have taken cutoff more than or equal to 0.515.
So this is for positive, na? This is for positive. See here written positive test result.
Okay.
Here, if you see the icon, let me show
Understood.
you again. So this is positive test level. That means in any cutoff, because see, there can be a cutoff where the less value is positive. Again, suppose there is creatinine and you are labeling something. So there the less than equal to will be your positive outcome. So that's why you have to express whether, that's why these signs are here. If you wish, suppose any cutoff where I want to take like normal ones, you can change this also. Suppose I want to predict normal. Remember the way we have done it for the logistic regression, where you can change the reference level. You want the odds ratio in healthy or in diseased. Similarly, if I want to predict some, so let's say I will take it as a less than. I can do that. Less than, because I am now saying the healthy one means not having the metabolic syndrome. So that means now you will see that it has got changed. Again, the same thing, but it has changed itself.
Yes.
Because now I have changed the cutoff, means I am now saying, and now you will see that it is writing benefit and benefit. You say initially it was writing harm, and it is also sign was now it's different, it's positive. Because now I'm saying that person who is having less of this BMI, he is a positive, means I'm saying healthy one. So now everything becomes
Yeah, true, true. Even the relative risk is just down to 0.03% if the
yes,
WHTR is less than 0.5. Understood.
yes,
Understood.
yes.
Understood.
Dr. Kamran, I think was it your question also?
Yeah. Now anything just about the odd ratio, the same point?
So odds ratio in this case it's 0.01. So it is you will say that odds of metabolic syndrome is only 0.01 in people who are having waist height ratio less than 0.51.
And same point, just reverse it. Go to back and then when was the odd ratio was now diagnostic positive is 3%. And totally it's a reverse of
Yeah, because you have changed the cutoff here. That's what I saw when Dr. Ravi said that,
yeah,
positive and negative things. So here you have to mention, you want to do this diagnostic ROC for labeling someone healthy or labeling someone diseased.
agree. Nothing here, no concern about the p-values, yeah?
Of course, p-value is there. I'm just keeping p-values here.
Okay.
Since you know all these concepts, so probably that's why I'm not going to up to this p-value. But again, it is significant. That means even these odds ratio and p-value, that is significant.
Agree, ma'am.
So is it okay up till this point?
Yes, ma'am.
Okay. So I think if it is okay, you people are now all options. There are few more options, but I think, yes, one thing I will just convey regarding this F1 ratio, there is initially I did not tell that F1 score. I'm not clicking that now because it will take too much time. But this F1 score, can you see there is an option of F1 score also? So this has added new to this Jamovi, this thing, that this F1 score also helps you it is like AUC. Again, one level ahead, you can say. It is good, AUC is good, but even if you give F1 score, so these days we were looking up for the recent evidence, and now everyone is now having F1 score also as one of the criteria for diagnostic accuracy statistics. So in the list of all these, F1 score also have been added. I'm not going into the detail of how this is calculated, but just remember this is like AUC. Here the cutoff we take 0.6, and if you wish to conduct any study, you can report this F1 score also along with the other diagnostic accuracy statistics.
Okay.
Okay, so if it is okay, I think we can call this as an end because this was like a very irregularly spaced workshop. We started with something and there was a lot of breaks in between, but again, we could complete it. So it is good.
Everything can't come under the curve, I think so.
Okay.
Hopefully.
So,
Thank you, ma'am. Thank you very much.
thank you. So I think you will the way because all of you are earlier participants, so you know all the how you get the certificate and all. I think any questions from any other participant?
One
Ma'am,
question.
I would,
Sorry.
yeah.
Yeah.
Yeah, please. Ravi, please carry on, please, sir.
No, no, ma'am, I just wanted to thank you for such lovely, wonderful sessions. And तहे दिल से आपका धन्यवाद देना चाहेंगे. And I would humbly request, ma'am, कि whenever you're having the next session on maybe SRMA or anything else for spam
Okay.
in the group, so I would humbly request, I would love to join back and listen to you
Sure. Sure,
and to
doctor.
your team.
Sure.
It's a brilliantly, very well conducted, all these sessions.
Thank
And
you.
there's a lot of clarity and so many things which you perhaps we had read during our previous days were not that very clear, which the software and you have really brought it out very clearly, ma'am. Thank you so
Thank
much
you, sir.
profusely for all the wonderful sessions, ma'am.
What's the next coming now, next our expecting workshop?
Dr. Shamshad is just flashing in front of me.
Okay, okay,
Next is like this thing, na? Kappa, agreement. We
okay.
have never conducted like Bland Altman and this Kappa, so we are doing, and it will be a one day because what we are seeing that now the participants like probably it's difficult to retain them. Uh,
Mhm.
So like we were planning that we'll have 1 day session of 3 hours, very small topics like agreement. So we are choosing topics which are small and which don't need to be present in all like 5-6 days. So probably that will, like YouTube shorts, you can say. Attention span is decreasing. So that's why.
Okay. Thank you very much. Thank you, ma'am.
So
Thank
it's
you.
next the agreement, which is in I think probably in July, na?
The 25th July.
25th July. So I think after,
Okay.
let's say 20 days.
So kindly request to Dr. Shamshad to share me the link so we can pay, because we are away from the India, so it's easier to we can pay
Sure,
online.
sure. I think that's the same rule will go. We first post to our participants and then probably to
Yeah.
anybody else.
So we are
So you will
the
have.
we will be the old customer. So whatever the coming, maybe sometimes we are not randomly checking that. So just give us the
Of
reminder.
course, I can understand. We will post it in the groups. Don't worry.
Thank you, ma'am. Thank you very much. Thank you, Dr.
It's our
Shamshad. Thank you
pleasure.
very much.
So thank you
Special
to
thanks to Dr.
everyone.
Shamshad.
Dr. Shamshad, you can say yes.
Thank you. Thank you, Kamran.
Thank you, sir. Thank you very much. Thank you.
Thank you, Dr. Shamshat, once again to you.
Thank you. Thank you, Ravi sir.
Okay, then we may end the workshop from our end. Okay. Thank you, everyone.